Good afternoon, everyone. I thank Dr. Muralidhar for inviting me, and the topic given to me is T in complex congenital heart diseases. The perioperative indications for T in a congenital heart disease center is the immediate preoperative definition of cardiac anatomy and function, which means we give a real-time diagnosis of the anatomy and function of the heart, which may be different from what cardiologists opined. And the second most important indication is the postoperative surgical results and function to be assessed by the transistor echocardiography. And it helps anesthesiologists in intraoperative monitoring of ventricular volume and function. And whenever it is there, please use it for adequacy of cardiac bearing. If you look at this article which has come in Anesthesia Analgesia in 2003, the role of intraoperative transistor echocardiography in pediatric congenital cardiac surgery centers. This is a study across 2 centers and it's an observational study. And they have analyzed 865 routine T examination, and 50% of the T imaging was done by the anesthesiologist with advanced training, remained by the cardiologist. And T produced surgical alterations in the management of around 30% of the cases, and it also caused a repeat bypass in around 7% of the cases. And the medical management changed around 90% of the cases, and it also predicted postoperative difficulty in 4% of cases. And if you see the importance of a cardiac anesthesiologist trained in pediatrically compared to the cardiologist, the supervision of such a person is requested in 37% of the cases compared to a cardiologist. So this study confirmed the utility of routine T in congenital heart disease. And this service can be competently performed by a regular team of cardiac anesthesiologists appropriately trained in transistor echocardiography. So is the importance of this topic. The probes which we use in our setup is an adult 3D probe, which is slightly larger than the adult 2D probe which we use in grown-up patients, which can be put in patients weighing more than 30 kg. There are 2 pediatric T probes, the mini multiplane probe and micro multiplane probe. And as I said earlier, the adult 2D probe can be put above the age of 25. If this probe is not there, one can use epicardial folds. This is the intraoperative comprehensive T form which we use in our institute. And it has 2 columns, the pre-CP or pre-surgical column and the post-CP. And every case, we need to assess the LV and RV systolic function, and also the systemic and pulmonary venous drainage. And every case of congenital, we need to look at left SVC also. The post-CP period, again, we look at biventricular systolic function. Some cases, we need to assess the QP by QS to assess the pulmonary blood flow. Now, if you look at the report form, we have diseases mentioned here, and below that, what exactly we should look with the echo, it is written. For example, if it is an ASD, we look at the type of the ASD, how is the shunt flow, whether it is a left, right, or right shunt or bidirectional shunt, and the size of the ASD, the gradient, the partial anomalous pulmonary venous connection is present or not. We look at the mitral valve, look at mitral regurgitation, tricuspid regurgitation. I look also for pulmonary stenosis, and if there's a pulmonary stenosis, what is the gradient? And again, the post-AV period, you look at the residual ASD and look for there's a stenosis across ASVC and IVC, especially patients with a deficient IVC rim. And this has happened occasionally that IVC was rerouted to LA and patient became cyanotic. So all these are important. These are straightforward congenital heart diseases. And when you go to the other diseases, the examination becomes a little more complex. For example, atrioventricular septal defect or common atrium, tetralogy of Fallot or VSD with pulmonary atresia, double outlet right ventricle, transversion of great arteries, total anomaly of pulmonary venous connection. The form also has how to image Epstein anomaly, what to look in the pre-CV period and what to look in the post-CV period, truncus arteriosus, anomalous left coronary artery from pulmonary artery, or the patient comes with a single ventricle. They can undergo either VT shunt or a central shunt or a PA band or a bidirectional line or a phone band. Depending on surgery, what you assess and what are the things you look in the pre-CP period. And if the disease is not belonging to any of these disease groups, then we have provided a space. So I'm going to explain how to look at a couple of complex lesions. And this is very important. Sequential segment analysis was already done by Srinivas. You need to assess the three segments: atrial segment, ventricular segment, and arterial segment, and the connections. In addition, we look at the venous drainage, the systemic venous drainage, pulmonary venous drainage. This is already being covered, so I'm not going into the details. And echo for congenital heart disease starts with looking at the X-ray. So this is a levocardia situation where the heart is predominantly on the left side of the screen. The base to apex orientation is from right, left, and towards the left. Whereas in dextrocardia, the heart is predominantly in the right hemithorax, and the situs may be inverse. So the right atrium on the left side, the left atrium on the right side. So this can be assessed in echo also. So please have a look at the X-ray before going with the transvascular perioperative examination. So the first view we see the metacervical portion, but this is a patient with the ASD. So the base to apex orientation from the left side of the screen, the right side, and this is levocardia. And the chambers are concordant. Whereas in dextrocardia, this is situs inverse and base to apex orientation is in the other direction, and this is situs inverse. So right atrium is to the other side of left atrium. Next, or anytime when you're doing the you should look at the pulmonary and systemic venous drainage, unlike in adult. For example, if you look at this patient looking at the left upper pulmonary vein, there is a turbulence there, and there's a gradient of pressure gradient of 7. This was notified to the surgeon. Now we're looking at that systemic venous drainage. This is a IVC and the hepatic vein draining normally into the right atrium, whereas this patient was operated last week. You can see that in the bicable view, the SVC was draining into the left atrium, and the surgeon rerouted to the right atrium. This is an alternative. It is not easy to image pulmonary veins easily in all cases. This is a conventional way of imaging pulmonary venous, left pulmonary veins. 5-chamber view, rotate the probe to the left, and you can see that inverted V, left and right pulmonary veins joining producing inverted V appearance. Whereas here, this is an alternate view. With the aortic valve long axis view at 110 to 120 degrees, turn the probe to left, we can see the both pulmonary veins. The vertical vein is the upper pulmonary vein, and the horizontal is the left lower pulmonary vein, and forming an inverted V. Similarly, the right pulmonary veins can be obtained from the view of RV inflow outflow, 45 degree, turn the probe to right, we get both pulmonary veins. Coming to a couple of complex congenital heart disease, I've taken Tetralogy of Fallot. This is the most common cyanotic congenital heart disease coming to our hospital. What are the things you should look in perioperative transvascular electrophysiology? Look at the BST. What about BST? Whether it is a subaortic, doubly committed, inlet, or muscular BST, there can be an additional muscular BST. Doubly committed BST will be more towards the pulmonary valve. Then you need to inform the surgeon. We measure the size and look at the shunt, whether it's bidirectional or right to left or left to right. Then, most important part is assessment of RV outflow tract obstruction, whether it is infundibular or valvular, or both. or there is a supravalvular component also, and measure the gradient. Preferably in the deep transective view or upper esophageal views, look for additional VSA which may be evident after surgery, additional AST or PDA, and if there is an AST, what is the shunt, and look for coronary artery crossing RVOT. Major aorta pulmonary collateral arteries present by imaging the descending thoracic aorta, and look every valve apart from pulmonary valve, aortic valve, mitral and tricuspid valve for their morphology and whether they are regurgitant, and it is not complete, examination is not complete unless you examine the biventricular systolic and diastolic function. So I'm going to show the images of 17-month-old tetralogy of Fallot, and this is the VST, which is subaortic, and this is a long axis. So you can see the aortic override and shunt is predominantly left, right, and right left component is also there. You can see the color change there, and here I am looking for a additional VST. You need to bring down the Nyquist limit to see the additional VST in this view as well as in transgastric views. And now looking at the RVOT obstruction, this is the pulmonary valve and upper esophageal view. You can see that the valve is thickened, there is doming, there is an obstruction there. It is a bicuspid valve, and there is a gradient, but the turbulence is coming below that. And if you look at that, there is an infundibular obstruction also. And there is so in this case, there is obstruction at the infundibular level as well as the valvular level, and surgeon repaired both. And you look at aortic valve for regurgitation. Aorta is usually large in the tetralogy of Fallot. Here there is no aortic regurgitation, and the tricuspid and mitral valves were all right. And this patient had a PF, patent foramen ovale, which is shunting right to left, and we need to look for the PDA also. This is from a different patient. You look for PDA in an upper esophageal aortic short axis view. This is the main pulmonary artery, this aorta, and this PDA. And arch also one can find out transistorography. This patient had a left arch, whereas in some patients see the right arch, and some tetralogy patients will have a coronary arteries crossing the RVOT will be evident here. That is most easily picked up by the transthoracic echo. And looking at the biventricular systolic function here, and not complete tetralogy with RV hypertrophic and diastolic dysfunctions also LV. So in this case, the final diagnosis was situs solidus, levocardia, atrioventricular ventricular arterial concordance, tetralogy of Fallot with subaortic VST, normal position of VST, classical bidirectional shunt. Right ventricular offer tract has both infundibular and pulmonary venous obstruction with the gradient more than 15 millimeters. The PO4 standing right left. There is no PDA, no additional VST. Normal systemic and pulmonary venous drainage. Biventricular systolic function were good, and there was some better relaxation of both LV and RV. Post-CV evaluation also important. We look for residual VST and additional VST. The additional VST become evident after surgery. If there is additional VST, you have to locate it, size it, and see how the shunt is from right left or left right bidirection from the surgeon. If it is more than 3, you go back and address that if it is successfully successful. The RVOT gradient should be around 30 millimeters, and if it is there, you need to tell them that it is in the valve level or infundibular level or supravalvular level. The surgeon puts the transvalvular patch. There is a chance of pulmonary registration. You need to quantify it. In difficult cases, they keep a small AST and look at the shunt and always assess biventricular systolic function. Now coming to another complex congenital heart is anomalous left coronary artery from pulmonary artery. A little bit about the anatomy of this lesion. This is a normal anatomy. This is aorta. This is a pulmonary artery. You have the sinus 1 given by the right coronary artery, sinus 2 given to left main coronary artery. What happens in ALCAPA is RCA is originating normally, whereas the anomalous coronary artery from pulmonary artery from the facing sinus. This is sinus 1 of the pulmonary artery. If it is arising from here, you need to tell the surgeon. It is not easy to bring the disconnect from here and bring it here. You need to do a long dissection or add additional graft if it is arising from the non-facing sinus. So this is a patient where is the aorta, this pulmonary. We have developed this aortic valve pulmonary artery short axis view is around 10 to 15 degree, where you can see both right coronary artery and left main coronary artery in a single view. And is the right coronary artery draining normally or supplying normally with the blue arrow here, and the left MCA having a red flow here. This is filling retrogradely. So what happened is, these are the things we should look in the pre-CV period. Left coronary artery origin from the pulmonary artery, whether it's on the facing or non-facing PA sinus. Whether there is a flow reversal in left coronary artery, which is in when the pulmonary artery pressure comes down. And if there is a myocardial ischemia, there can be mitral regurgitation or rigid motion abnormality. Also look at the RC and aorta ratio. This gives idea about the collaterals between the right coronary and left coronary artery. If it is more than 0.3, there is adequacy of collaterals. And post CBB, again look at the flow, whether it is laminar, obstruct, or reversed. And look at MR. And the patient requires mitral valve repair or replacement, you need to assess that. So this is what is exactly happened in our case. Is a 12-year-old boy. This is aorta, this is pulmonary artery, this is RCA. You can see the RCA flow here, move away, and this is the left main coronary artery. And it was dividing into circumflex and LAD here, and there is a red flow. This is in the reverse direction, and shunting, left coronary artery shunting into the pulmonary artery. And there are adequate collaterals between the right coronary and the left coronary artery. And this has to differentiate with the from the VST. And we had put a 3D probe, and you can see the left coronary artery origin from the PA, and right coronary artery origin from the aorta. And if you put the pulsar Doppler, there is an antegrade flow in the right coronary artery flow, and the retrograde flow in the left coronary or left main coronary artery. And this is after surgery. This LMC was taken from here and translocated to your aorta. So this LMC, this circumflex, LAD, aorta, and there is a blue flow here. So, and there was no rigid wall motion abnormality, no MR, and this was a successful practice. This is how you systematically analyze and do echo in complex congenital heart disease. And I don't have time to go through all lesions. And to conclude, I'd like to say that what is most important is that congenital heart disease evaluation is a structure-based and not a view-based approach, which we employ in adult. So we need to look at each structure separately. And the angle may be different, the rotation may be different, and evaluate that. And there is no definite 100% view for example, left SVC or a pulmonary venous drainage. Always assess systemic and pulmonary veins, the drainage, atrioventricular ventricular arterial connections. These are been already dealt with the previous speaker, and use 2D, 3D, and Doppler, and do a segmental analysis whenever required. Thank you very much for your patient listening.